Dr. Schoon just wanted me to mention from the previous presentation that he has his printouts of its emergency cards, I think, that will be outside of this room, possibly on one of the tables. He has about 100 copies if you'd like them. And we will go ahead and get started with our next highly anticipated presentation. So this is the start of our spotlight sessions on specific symptom areas. These topics, the next 4 or 5 topics, were voted on by the community as top priorities, and I see many of you have attended, which is a great sign. Each speaker in this series will share their most current knowledge in their symptom area, as well as resources that you can access for management of these symptoms. These speakers are highly dedicated in their expertise, and we hope you take a lot from these sessions. And without further ado, I'd like to welcome Patty O'Boyle to introduce our first speaker.
Welcome to our session on neuropsychiatric illness, regression, and challenging behaviors. We are privileged to have Dr. Teresa M. Kohlenberg, who many of you know as Tesi, from her active role in this community. For those of you who don't know Dr. Kohlenberg is a well-respected pediatrician and psychiatrist who has dedicated her career to understanding and managing complex neuropsychiatric illnesses. Dr. Kohlenberg, an assistant professor in psychiatry at the University of Massachusetts Medical School, has published significant research on psychiatric illness and regression in individuals with Phelan-McDermid syndrome. As a leader in the Phelan-McDermid Syndrome Neuropsychiatric Consultation Group and a member of the PMSF Medical Advisory Committee, she brings invaluable insights into managing and preventing these issues. Dr. Kohlenberg is also the mother of an adult daughter who was diagnosed with the SHANK3 variant at age 16, 2 years after she developed complex neuropsychiatric illness. Dr. Kohlenberg will share what we have learned about managing neuropsychiatric problems, prevention strategies, and supports available through the Foundation. Please join me in welcoming Dr. Kohlenberg.
You did. Okay. First of all, can you hear me with this lapel mic? And I can't see you all, so give me some feedback in words. Yeah. Okay, good. I'm so grateful to the Foundation and to Patty for her kind introduction, and most of all, to all of the families here who have shared their experience over time, which has been just huge. You'll notice that the title of today's talk is not quite what it's billed, and that is because including challenging behaviors was beyond my scope. So this is what we know now in a world that continues to evolve. Battery, perhaps? First, the mandatory housekeeping. I have no conflicts of interest to declare. Today's talk is focusing on neuropsychiatric illness and regression that can develop in the teen and adult years with the primary goal of equipping parents here to recognize these disorders and to advocate for appropriate treatment. So this is not going to be predominantly a data-focused talk. Ann Neumeyer will talk to some extent about challenging behaviors later today. So I haven't dedicated my career to complex neuropsychiatric illness. It was really after our child became ill that I started to learn and work in this field. Before that, I was a very ordinary ADHD and depression kind of psychiatrist. But that experience led me to reach out to our community to learn more about these problems, which led families to share their experiences, which led to a series of in-depth interviews over 2 years, which led to a paper that was analyzed and written with the help of some wonderful experts who are in the room and some who are not. And that helped with a growing understanding of this illness pattern and led to the development of the consultation group, which also involves wonderful people who are in this room. Now, one thing I'm going to mention is today will involve a lot of videos of people both well and ill, and some of them may be uncomfortable to watch. You may want to think, if you have children in the room, about whether it's appropriate. So this was the paper that came out of the contribution of long talks with parents. Was published in 2020 and leads us to the big questions. How common is psychiatric illness in Phelan-McDermid? What does it look like? What provokes it? Is there anything we can do to prevent it? And what resources are out there for our families? How do we know what we know so far? Well, most of the published studies are based on clinic samples of people who are already psychiatrically ill. And while this helps us to describe patterns of illness, it can't tell us what proportion of people will develop this kind of illness, and it can't tell us whether a given individual will develop this kind of illness. We learn from research, we learn from families, we learn from consultations with our experts, such as Liz Berry-Kravis, who may be in the room. We learn from the natural history study, the registry and data hub, and we hope from the new immune mechanism study. Just want to point out this graph of the current ages of currently known people with Phelan-McDermid to point out that we're talking about a problem that tends to develop in adolescence and young adulthood in a group of people, most of whom are under 20. So we're going to learn a lot more over time. How common is it? We have over 200 PMS families who are dealing with serious psychiatric illness and who connected through social media and through the foundation. The Neuropsychiatric Consult Group has consulted in depth on 71 cases. We know of perhaps another 40 cases in Europe and Latin America, but we don't have a denominator. So we can't say how common this is yet. And before moving into the symptoms that we think about, it's really important to note how many symptoms that appear on psychiatric diagnostic checklists are in fact part of the phenotype of people with PMS to begin with. And if they're not new symptoms, it's important not to necessarily count them towards a new diagnosis. Can everybody see this symptom list? Okay, then I'm not going to read it to you. Accurate diagnosis requires putting behavior in context. Parents can help doctors make accurate diagnoses by being clear about which symptoms and behaviors are new or dramatically worse, and which ones are part of how this person has always been. Videos and behavior logs are worth a million words. They really are. And any family that's gone in to a neurologist or a psychiatrist without videos knows how hard that can be. So I strongly suggest that you take videos of your child's typical behavior, communication, ways of moving their body through space, of using their hands, of their self-care skills, remembering to show your child happy in their favorite activities, and keeping a log of sleep and poop because they're just almost always important. Somebody like that. Behavior changes can be set off by medical causes and pain. They're not always psychiatric. And so this is the list of things that have caused severe behavioral change in people that we know of and that really need to be thought of early on in the evaluation of behavioral change. What can trigger new psychiatric problems in Phelan-McDermid? They tend to start during puberty and young adulthood, and we think that's a combination of the impact of hormones on the brain and also of the strain of social transitions and aging out of certain kinds of programming and into others. They can occur after a stressor such as a medical illness or procedure, when services and supports change, and at times of family transitions such as an older sibling moving out of the home. They can also happen after people are exposed to certain medications, among them antidepressants, antipsychotics, and some anesthetics that are structurally related to antipsychotics, or in fact, were initially developed as antipsychotics. Does the type of genetic difference make a difference in how likely you are to have problems? A strong maybe. There's data suggesting that psychiatric illness can occur in all forms of Phelan-McDermid, but it appears to be diagnosed far more often in people with SHANK3 variants or smaller terminal deletions than it is diagnosed in people with larger terminal deletions and rings. What kinds of psychiatric problems do we see? Pretty much everything. Anxiety disorders are often the beginning of a period of instability, obsessive-compulsive disorder, the mood disorders, mania, depression, bipolar disorder, the psychotic disorders, catatonia, and I put regression in brackets for a reason. We'll talk about that later. I'm going to use our daughter as an example because she's had almost everything you can have. So she started having manic episodes with her periods at age 14. They were about 9 days long, and in between, she would return to normal. Over the next 4 years, she had 10 episodes ranging from 10 days to 3 months long, including mania, depression, OCD, and catatonia. So we're going to talk now about what specific problems can look like. And it's very hot up here. Mania involves a spell of days to weeks or even months during which a person sleeps much less but doesn't seem tired. So this is not just insomnia, this is a decreased need for sleep. Has high energy, moves around more than usual, may talk or vocalize more or faster or more loudly, may be excited, silly, bossy, or crabby, does new, impulsive, or dangerous things, which can include sexual behaviors, stripping off clothes, running away, unsafe climbing. These are all things that are new for that person. And may have new, intense repeating of behaviors or goal-directed projects such as organizing things, giving things away, or emptying and strewing. Which, can I see a show of hands for emptying and strewing? Yeah, the pros are in the room. Here is one of our kids at the beginning of a manic episode, and in this you see the silly, giddy, loud, impulsive features.
It's recording. Calm. You want to tell the foreigner.
And this is not typical behavior for this child. This young man in a manic episode demonstrates the loud, repetitive, and driven quality. You get the sense that he might like to stop, but he can't.
Do you have to touch a monkey, Mommy?
I can't right now, Bo. Maybe you could relax a little.
By the way, monkey, you have to get a monkey. You have to get a monkey to the egg.
And this young man shows the endearing, jolly, silly, and absolutely exhausting face of mania.
Oh, check your pants. Check Grandpa's pants. Oh boy, check Grandpa's pants. Oh boy. Oh boy. Hey.
So that's mania. What can depression look like? Well, I'm not going to show you videos because I think many of us know what depression can look like. People lose interest in the things they used to enjoy. They may seem withdrawn. They may sleep more or sleep poorly, but either way, they look tired. They move slowly. They may seem lacking in their essential spark. They may be sad or fearful or irritable. And they often have changes in their interest in food, which can go either way, eat more or less. And they can lose self-care skills. Neurotypical people lose self-care skills during severe depression. It's not a surprise if people with developmental disabilities do too. Anxiety disorders and OCD can be hard to recognize in people who can't use language well or can't tell us what they're thinking or feeling. And also repetitive behaviors, rigidity, and obsessions with favorite objects and activities are common in our population at baseline. So it can be hard to tease out. Anxiety can look like refusal to go places and see people they used to enjoy, new fears, resistance to separation, irritability, new, different trouble setting to sleep, agitated behavior with attempts to escape from situations that are anxiety-provoking, frantic grabbing at caregivers, which may be a form of panic disorder. I think somebody's in this room who described to me that their child grabbed onto them and climbed them as if they were a tree. And it's possible to read that as aggression, but when you look underneath, you see that it's fear. And you see signs of adrenaline overload, such as restlessness, diarrhea, rapid heart rate, trembling, or pallor. OCD, again, I think we have at least a media-generated idea of OCD. In our population can look like, again, strewing, emptying, piling, or moving things, picking at their skin, at their hair, at their clothes, at furniture, or bits of fluff on the floor, repeated questions looking for reassurance and just not ever feeling settled, and frustration and lashing out if someone gets in their way when they're carrying out the compulsions that they feel. So this was one we lived. At age 16, overnight, our daughter developed a fear that something bad had happened or was going to happen to the cat. And the first night of this, I counted how many times she asked because I thought I might lose my mind if I didn't do something with it. Got to over 600 and stopped counting. For the next 3 months, she needed to be within a few feet of the cat night and day. And this was not fixed by any psych meds. Here she is watching a cat who's watching birds.
She's fine, she's right here.
And this is how she was
She's okay.
all day. She couldn't go to the bathroom because that meant getting further away from the cat. Derek, can you pause the first video and move on to the second?
Mommy, she's right there on the floor. And she's gonna come when she wants to come.
Okay, you can stop
Mommy,
it.
she's right here. You don't have to worry about her.
So that was what nights were like. And there was very little sleeping going on, and we were all in one room with a litter box and an unbelievably compliant cat and an unbelievably distressed child. On to psychosis. So psychosis is the term we use for things like hallucinations, so seeing things or hearing things that others can't see or hear, delusions, so believing things that aren't real, disorientation, confusion about people, places, time, routines, bizarre behavior. One person described their child repeatedly running into the wall at full tilt and bouncing off it, a behavior that didn't seem to do anything useful but couldn't stop. And over time, deteriorating function in thinking, relating, and self-care. Psychotic symptoms can occur in the mood disorders, such as depression and mania, and can also occur in what we think of as the mainly psychotic disorders, like schizophrenia or schizoaffective disorder. It's hard to be sure of in people who can't or don't communicate their ideas. So this is about as much as we're going to talk about aggression, which I have largely left to Ann Neumeyer. But just to reflect that some people have aggression as part of their baseline repertoire of communication and self-expression. They may just pull hair or bite because it gets exciting reactions out of people, or they may do it when they're frustrated, or they may do it when they want something. Aggression can also appear newly in mania or catatonia. It can be severe and it can be purposeful, someone who's really trying to hurt other people, but it can also be kind of incidental when someone's driven and they almost, they can run through another person as if they were not really there. There's a sense that the drive is what's important, not the hurting. And these different forms all have different meanings and different treatments. Now, the first video, I don't have a well baseline for this young man, but he's a really fun, nice person. And here he is in mania, and that's his brother who's trying to keep him from leaving the house.
You're gonna spill the drink on me. You're gonna spill the drink on me.
And who is remarkably calm.
Yep, pull harder. Yep, can I have that?
And a couple of days later, out of the blue, he attacked his little brother, and this was caught on something called a Furbo, a household monitor.
No! Deep brother!
So, part of this was due to the introduction of an antipsychotic that he was not tolerating well. With a change in his meds, removal of the antipsychotic, he came back to his baseline.
How about this one over here? Hey, Jared, what are you doing? What are you doing? Jared, come over here and water this plant, honey.
I will try throughout this talk to show you people when they're better. Catatonia. What about catatonia? There's a lot of buzz about it in our group. Catatonia is a rare disturbance of movement and behavior that can accompany a variety of psychiatric and medical conditions. It is definitely more common in people with neurodevelopmental disorders, particularly autism. And interviews with our parents suggest it is an order of magnitude more common in Phelan-McDermid patients who are having psychiatric illness, and that the diagnosis is often missed, which is really unfortunate. There are several types of catatonia. The one that's in the movies is called stuporous, when someone is slowed, stuck in various positions, unresponsive interpersonally, and stops vocalizing or speaking. There's also a kind that I had never heard of until we encountered it called hyperactive or hypermotoric or excited catatonia, which involves constant movement of a driven, can't stop sort, often with repeating behaviors of sounds or words or motions. It looks like mania with extra symptoms. And then there's neuroleptic malignant syndrome, which is a complication of catatonia, which can include fever, oscillating heart rate and blood pressure, and lead to muscle breakdown and kidney damage and require ICU care. And we've had, I think, 3 cases of NMS in our community in the past 6 months. So it's an extraordinarily rare complication, but perhaps not so rare in Phelan-McDermid. It's important to know that all of these forms can be triggered or worsened by antipsychotics, not just in Phelan-McDermid, but in neurotypical people. So a little parenthesis about antipsychotic medications. This is a highly personal view. I put the name of some of the more commonly encountered ones up here. They are powerful medications with notable short and long-term side effects. Some of them are approved for irritability in children with autism. And in this period of psychiatry, because of their powerful and rapid effect, they're increasingly the first-line medication that a psychiatrist or a behavioral pediatrician or a neurologist or an ER doc will reach for in dealing with, as you can see, quite a long list of possible problems. Listening in the parent community in PMS, my impression, and there are not data on this, is that they are tolerated and helpful in some younger children with Phelan-McDermid and being used. But given our experience with the older population, I think they should be used thoughtfully and with caution, especially if there are mood problems due to the risk of side effects in catatonia. Now, I want to mention some of catatonia's unusual symptoms because they are really very striking and very unusual. So we'll see examples, but one of them is getting stuck in odd postures, postures that look like they'd be hard work to maintain and not particularly comfortable. Changes in motor pattern for gait or the body angle while walking. Difficulty crossing visual boundaries. So you hear about kids who hang up at the edge of the rug as if maybe the step onto the wood floor was going over a cliff, or they're unable to come downstairs where previously this was easy. Difficulty making ordinary body transitions. So someone who approaches the sofa that they usually, trump over to and sit down on, and when they get there, they circle, they look puzzled. It's as if they've forgotten how to execute what was before an ordinary motor sequence. Similarly, we can see a change in the ability to manage saliva or food in the mouth, which means that during such spells, people who may have been competent and safe self-feeders are not. And that's one thing I really want to say clearly today, that kids in this condition are at risk for choking, even if they weren't before. You can see food refusal, where someone just turns their head when you approach them with food, rapid weight loss of 20, 30, even 50 pounds, inability to release urine, which is called acute urinary retention, odd fluctuating changes in skin color, so the hands may go white and blue. Now, if these are things that were always there for a person, they are not considered part of catatonia. But if they're new, we're interested in them. Odd red patches on the upper body, neck, or face that look like hives, but they're not raised and they're not itchy and they come and go. And new repeating phenomena, as I mentioned before. So these 3 videos show examples. The first one, Derek, if you could help, I guess I can start this one. This is posturing.
What you doing?
You talking about your movies?
Do you want to put your arm down?
You won't have a squirrel.
Next video, please.
We might have a squirrel.
Oh,
Might have a squirrel
not the
in a little
third one
cage.
is running. Can you stop
Might
the
have a
third
squirrel in
one?
a little cage. Might have a little squirrel in the cage, and you might.
So this young woman is frozen. She's
Emily?
trying to mobilize and she can't.
Kom, lopen we even verder. Kom maar, Emily. Boefje. Kom maar, gaan we deze kant op. Loop je mee? Emily, loop je mee? Kom maar, kabouter.
And then finally, she gets herself
Come on,
freed
Bookie.
up. Third birth video, please. And this last one is repeating.
You won't have a squirrel. We might have a squirrel. We might have a squirrel in a little cage. We might have a squirrel in a little cage. We might have a little squirrel in the cage, and you might get to hold it. You might get to hold it. You might get to hold it. You might get to hold it.
Okay, you can stop.
You might get to hold it.
So that's the sort of broken record quality. Whoop. So catatonia is rare in general, but more common in Phelan-McDermid, and I'm going to show you, with the generous help of a number of our families, what it looks like. Here is Sarah at baseline dancing with her little niece. Sarah was hospitalized for mania and agitation, which had happened before to her, and she was treated with 2 antipsychotics at the same time. While on the psych ward, she fell, she hit her head, she vomited and choked, and went to the ICU for a presumed aspiration pneumonia. This was during COVID, so her family couldn't visit her and weren't able to inform the hospital team of how altered she seemed. A week later, she was discharged, mute, staring, and so stiff that they had to have 4 people to kind of half carry her to the car. 2 days at home, she was admitted, this time medically, to a different hospital because she couldn't walk or eat. And she remained in the condition I'm about to show you for an entire month in the hospital. The hospital team thought that she'd had a brain injury in the first hospital. They didn't think she was going to recover, and they recommended that she go to a long-term nursing facility. Her family, which was in contact with us, knew that there was a possibility that this was catatonia, and they kept asking for a trial of lorazepam, which is the specific medication for catatonia. It was finally tried, but the dose was increased very slowly and stopped at a mid-range, and she only got a little bit of recovery. So after about, I think it was 5 weeks, they tried electroconvulsive therapy, which is a magnificent treatment, and she got completely better. I think she had 12 treatments. Here she is after finishing her course of ECT. She's been stable for more than 3 years with no recurrence. She's singing, just to be clear. So this is another Sarah who developed manic spells and hallucinations around age 13. She was started on risperidone, had muscle stiffness, and stopped eating and had to be hospitalized for tube feeds. The risperidone was stopped, she was sent home, saw a new psychiatric provider who started her on a different antipsychotic, Abilify, aripiprazole. And some months later, she developed these new gait changes.
Why don't you stand up straight? Now, doesn't that feel a little better? Can you hold your head up?
This progressed, and she was admitted to hospital again and needed ICU care again with a feeding tube for nutrition and to protect her airways if she wouldn't aspirate. Lorazepam, Ativan, was tried, and she was even given a dose of intravenous immunoglobulin, but it really didn't help. So they decided to try ECT. This is her before the ECT.
You swing your feet around. Yeah, we'll get your glasses. All right, here you go. Keep going. There's your right one. And swing. Good job. All right, let me scoot. Ready? All right, get your feet straight. Can you straighten your feet, uncross them? All right, you ready? All right, straighten your knees out.
Hold your head up.
Push, push, push. Hold
Push.
your head up too. All right, lock your knees. All right, can you take steps to the chair? Whoa, whoa, whoa.
This is her the day after her first ECT treatment.
Good job, you're playing.
And she then had a course of ECT therapy, and this is important for recovery from such an intense brain experience. So she had PT and feeding therapy. She went home. This video is a year later, and I want to say that since then she's been stable for 8 years with maintenance ECT treatments every 8 to 10 weeks. Here she is receiving her belt at martial arts.
Yay, Sarah!
This is Immy. The first video is of her at baseline. She was 10, and then the second video shows her having manic spells with very new aggression and self-injury. At this point, they were being treated with clonidine, which wasn't really helping. Oops, wrong video. Help here.
We've got Archie walking with you. And a whole lot of people.
Okay, next video, please.
Im. Hey. Immy. Imogen, stop attacking.
Come on, let's put your hoodie on. Ready? I'm in. Okay. Do you need help to do it up? Do you need help?
Next slide, please. She was treated with risperidone eventually, which did seem to calm her for a few weeks, and then she had this crisis. She was admitted to the hospital. She was completely immobile. You see this very bright red flushing all over her. She had fever. This may have been neuroleptic malignant syndrome. Risperidone was stopped, and diazepam, which is a cousin of lorazepam, of Ativan, was started, and she recovered. But here she is, acutely catatonic. And here she is, I think this was last week. She's now on different meds, a very small dose of aripiprazole, and she's happy, and as you'll see, chasing kangaroos.
Can you see some kangaroos? Where are they? Over here. Gonna go find those kangaroos? Go on, you go find them.
And look at the fluidity of movement that she regains with appropriate treatment. So that was stuporous catatonia. Now we're going to talk about excited or hypermotoric catatonia. Many doctors will never have heard of it or seen it. It often begins during a manic episode, and it overlaps in a lot of ways with mania. But the additional specifics are things like fast and mumbled speech, trouble managing saliva, holding food, sort of pouching food if this isn't a common thing already, not swallowing, refusing food, and repeating behaviors. And this is our girl who had one such episode at 18. She had also a first seizure, so we were in children's. And in this video, you'll hear the repeating, the decreased articulation, and also something called clanging, where she says words that rhyme with words she just said or someone else said.
She's gonna change some blood, okay?
Higher.
It's gonna hurt a little bit. It's gonna hurt a little bit. It's gonna hurt a little bit.
Just a little pinch, okay?
Just a little pinch. We're gonna put some blood, some blood, just a little blood, just a little.
So she had a 48-hour EEG, courtesy of somebody who's in the room, I think. And then she got an intravenous lorazepam challenge. 30 minutes later, she was completely her usual self, and she stayed her usual self until the time when you would expect the lorazepam to wear off, at which point all of her catatonic symptoms came back. She's been receiving intravenous immunoglobulin every month, low-dose lorazepam, and a cocktail of mood stabilizers since then. Here she is, better after lorazepam.
The neurology doctor was saying that it's like too far out to react to the IVIG. She thinks it could be from the Ativan though. So we'll give the Tylenol, if that sounds good to you. Oh my gosh, I love seeing that smile. Okay.
You would say?
So, and it's been 6 years. She's had one episode of mania for 1 month. Other than that, she's well and happy. Here she's shoveling snow and talking in something called her Elfie voice, which she uses to be cute.
I have to go and find her a lunch sometime, right, Mom?
Yes. Derek, what's happening with the video?
Is it going to be a fruit bat lunch or something more sturdy? Yes.
A fruit bat lunch. I don't know what
Is it going to be a fruit bat lunch or something more sturdy?
Sorry, we've got some sort of overlapping audio track. All right. At any rate, she was shoveling snow. Here is Mikey at baseline. Here is Mikey during a phase of hyperactive catatonia. One of the flavors I want you to take from this is the sense that this is no fun for him. He wishes he could stop, but he can't because his body is just going to do this.
Go to form. I don't know. The last few days, it's been intense with this energy. I don't know. It's starting to look a little more anxiety related, but again, we know this is.
And here he is on lorazepam, 5 milligrams 3 times a day.
Hey, today is October 2nd. Michael, say hi. Just taking a video of Michael today. He's on the 5 milligram Ativan 3 times a day. He's doing.
On to regression. Regression is great fear, I think, for every PMS parent. There are clearly a group who have skill loss in early childhood. There seems to be another peak of incidence around adolescence. I want to highlight that it is really important to note whether the loss of skills comes and goes with episodes of illness, whether other medical illness or psychiatric illness, or whether the loss of skills lasts for months when the person is not in some kind of crisis. I think we really need to separate those in our thinking about the thing we call regression. And it's also important to know that some psychiatric drugs can cause what looks like regression. So what do we know about regression in early childhood? It's reported in many small studies. It's well known in autism. Ryerson and colleagues at Stanford took a group of 42 Phelan-McDermid patients, most of whom were under age 18, and took extensive histories and did concurrent exams. About 40% of those families reported that their individual had had a regression. A third of those had regressed before age 2.5, which is the more typical autism story. 2/3, the larger number, had loss of skills after 2.5, usually by age 5. Most reported loss of motor and self-help skills, and 40%, less than half, but not a trivial number, did regain their lost skills. Regression is clearly associated with psychiatric illness in Phelan-McDermid. In our interview study of caregivers of 38 people with Phelan-McDermid and psychiatric illness, 2/3 reported loss of skills after the onset of psychiatric illness. About half of those regained those skills, particularly if they had rehab services after their acute insult. There's a very small group of individuals who are over age 30 with psychiatric illness, and some of them have had permanent and dramatic loss of skills, while others may have, frequent recurrent psychiatric bouts, but come back fully to their premorbid functioning in between those episodes. And we really can't predict yet what this will look like with time, with supportive treatment, and with avoidance of some of the medications that we now know are probably not the best thing to give people with Phelan-McDermid. What do we know about regression in adulthood? I think I've covered some of this already. The parents who have older kids who've had significant regression and really lost a great deal of skills usually describe that starting with psychiatric illness and often getting worse in a sort of stepwise way after infectious illnesses, which is an intriguing pointer towards maybe there being an inflammatory immune component. We don't know how common this is, and there's a couple reasons we don't know how common it is, but the biggest one is we don't know what the denominator is, right? We know that typically the older patients being diagnosed now are being diagnosed now because they've done something different, and they've had a doctor who knew enough to think about the possibility of repeat genetic testing. So how many people are out there in the general ID ASD population who have Phelan-McDermid that hasn't been diagnosed because at the time they got their investigations 20 or 30 years ago, the kinds of testing we have now were not available. So, while it's clear that some teens and adults with Phelan-McDermid do lose skills, it is essential not to accept all skill loss as PMS regression. And here's why. Chronic catatonia in Phelan-McDermid can look like regression. And we're going to talk about Chris, and I'm going to bless his parents for letting us share so much of this information. Chris is now in his early 40s. In his teens, he was a talkative, social, sporty kind of guy with moderate intellectual disability who was actually quite independent. He could come home to an empty house, operate a numeric keypad to get in, make himself a snack, and be left on his own for a few hours. This is Chris in a healthy state. Love his coordination. Around age 20, Chris moved into a group home, and he began to have episodes of irritability and aggression and was started on antipsychotics. Over the following years, he slowly lost many skills, including continence, motor skills, most of his language, many self-care skills, and I gather his memory for the past and past events and people. These changes were thought to be part of PMS regression. This is what he looked like in his late 30s or early 40s.
First time I've seen as many people back there.
When he was 40, Chris's parents learned from our community about catatonia in Phelan-McDermid, and they asked his psychiatrist to support lorazepam trial. I was running alongside in this period. It was a long push to get them to accept doing the trial, and when it was done, it was increased very slowly, which is not how lorazepam works for catatonia. Also, the nurse who was the kind of medical director of his residence was really not comfortable with having higher doses of lorazepam and simply refused to allow him to live in that house if the dose went above 8 milligrams per day, which is not all that much. Chris had some improvements in function, but nothing like what we would have hoped for. And then about a year into this very slow titration of the lorazepam, he stopped eating and drinking. I don't think we know why. Maybe he had an upset stomach. Staff couldn't get meds into him for 2 days, and he lapsed into full stupor. When I talked to the ER staff, they thought he might have had a stroke.
I know, buddy.
So after they had ruled out stroke and a bunch of other things that were reasonable to think about, they started treating him in hospital with lorazepam. And when the lorazepam reached about 20 milligrams a day, about a month into his hospital stay, he really came out. But during that month, he'd lost a lot of weight. He had a G-tube for nutrition. He developed contractures from lying stiffly. So he wound up spending 100 days in hospital and rehab. And then his group home refused to take him back because he was on a higher dose of lorazepam. So suddenly, after 20 years out of his home, he was returned to his amazing parents' care. And at home, he steadily improved. He has regained skills that were long thought to be lost. He now walks easily and independently. He speaks in sentences. He remembers the past. He feeds himself a full normal diet. He sings. He tells jokes. As you'll see, he teases. He's enjoying sports again, and he's regained some amount of his toileting skills. This is a couple months back. The group home finally took him back because they loved him and they were really impressed with how much he'd improved. Here he is with his dad a year after the catatonic crisis.
Is this 17, 18, 19? Today is 19. Oh, wait a minute. Let me look. It is 21. I made a mistake. So,
No.
Where is it? What month are we in? March? Let me get my glasses, Chris. You know I can't see without my glasses. I need glasses. Let me see. Oh, here we are, right here. That's where we are.
No, 21st.
You're right, you're right. That's it. Give me 5, man. That's right.
Where's our person coming in here?
Who's that? I heard.
Paul.
Oh, I heard Paul. You like Paul?
Yes.
Nice guy?
Yes.
Good.
He's not putting headphones.
He's got headphones too?
Yeah.
So I know it's hard to hear all the words, but you get the point, right? So on to the next question. Does the immune system, what's that? 5 minutes. Ouch. So maybe there is a small group of people with Phelan-McDermid and psychiatric illness who respond to immunomodulatory treatment, among them my child, some other children in this room. We have one published case series on this. In general, in psychiatry and neurology, there's a great deal of interest in the role of infections and inflammation. We do not yet know who this approach is appropriate for, and we're actively working on that in the study that the foundation was funded, which has just opened for enrollment. Hint, hint. This is a study looking at immune and autoimmune mechanisms of neuropsychiatric decompensation in Phelan-McDermid. I'm not going to go over the goals right now. You can read them on the poster out there. If you have a child who's over 10 with or without psychiatric illness, you can help us learn more about this. It's largely a survey-based study. A very small number will come to Boston for blood work, but you don't have to be able to come to Boston to take part in this study. Is there anything we can do to prevent these problems? In consultation with your medical team, consider these things. I can't overstress the importance of poop, of clean teeth, of a healthy diet with good micronutrients. Dr. Persico will be talking this afternoon about the impact of metabolic and nutritional interventions, and I think these are really exciting things for us to be thinking about. There are medications to avoid, particularly the antidepressants and the antipsychotics. This doesn't mean that antipsychotics should never be used, but they need to be really thoughtfully used. There's no one-size-fits-all treatment. We do have guidelines from the Neuropsychiatric Consultation Group. They're available through the foundation website. They are currently under revision to bring antipsychotics lower on the list of things one might try. So stay tuned for a new iteration of the treatment guidelines. Consider a neuroimmunology consult. And if you are in deep weeds, see if your doctors would be willing to consult with our team, which does in-depth case consultations twice a month. And I just want to bow to the many people who give their time to that group's work. I'm not sure who's here in the room, but many of them been at this conference. So the summary slide, I think you can read for yourself, and I may have even brought it in time for questions. Yes, Kate?
Thank you so much, Dr. Kohlenberg, and you have 13 minutes for questions, so this is perfect. I think this might be our most attended session besides the opening, so this is a really important topic. I have a couple of questions already populating, but soon the poll will be up on the screen and you can scan the code or upvote the questions that you find most important. But I'll start with what's in there now. So do you think IVIG is only effective alongside some of the other medications you mentioned, or can it be helpful to treat neuropsychiatric illness on its own, obviously knowing that it will depend on individuals and their symptoms?
Yeah, I don't think we have an answer to that question yet. It's a great question, but this is a complex illness, often involving disturbances in lots of different axes of function. So I think our neuroimmunologists might say in a really hot onset case with a positive workup for autoimmune encephalitis, that is when you can identify a specific marker that goes along with brain on fire, which is how many people know about autoimmune encephalitis. Perhaps IVIG or other immunomodulatory treatment would be started initially, but most of our kids need a more broad approach.
We have a great top voted question, which I think a lot of people want to know. How early should they, if they're recognizing these things, could it be a sign of neuropsychiatric illness? Specifically, is it possible to start seeing these episodes or symptoms around age 9-ish?
So I think it is, and we've heard, puberty is moving left, moving younger steadily over the years, partly due to the endocrine disrupting chemicals in the environment and probably other factors we don't know about. But I think it's important to say that when this happens, though it may onset gradually with anxiety and subtler sleep disruption, when it really hits, something's going on. This is not subtle.
The next question is specific, but also more broad, probably to everyone, but why would anyone be against increased doses of lorazepam? They specifically ask, why was Chris's inpatient home against increased?
Lorazepam is a controlled substance. It's a drug of abuse. There's a lot of concern about dependency and addiction and diversion, which means somebody else is getting a hold of this chemical and using it in inappropriate ways. And so we, as psychiatrists, are trained to minimize exposure to such drugs. And if you haven't done this before, certainly when I first ran into it, the doses just caused the top of my head to fly off. I think it takes support, and that's part of what the NCG team does, is support local providers not to be afraid of using these medications. When you think about the severity of the side effect burden of some of the other meds that our kids are often placed on, I'm not so worried about lorazepam.
Is there a known correlation between gene deletion size and neuropsychiatric occurrence?
There are now 2 studies, I believe, that report a significantly higher recognition of these problems in people with SHANK3 variants. Now, you'll notice I phrased that very carefully, and that's partly because overall, people with SHANK3 variants may have a larger behavioral repertoire to observe being disrupted, but it happens in all. We have people with ring and IMI, who I showed you, the Australian girl, has an 8 megabyte terminal deletion. So it's certainly not just people with small deletions and SHANK3 variants.
Thank you. Do many individuals go through regular cycles of OCD anxiety, say monthly, for a few days and then go back to baseline?
I don't know enough to answer that question. I have spoken with some families who report things like that, but there aren't any data to answer that with.
Have you found propofol to be a potential trigger of neuropsychiatric events?
I don't give propofol, and I haven't heard it reported as a trigger. In fact, I believe the Medical Advisory Committee anesthesia letter would say that it's fairly safe.
I saw a question earlier, I think it might have been further down on the list, but is the immune study accessible for families outside the US?
If they're really, truly English-speaking and comfortable answering a whole lot of questions in English, absolutely. Obviously, they wouldn't come to Boston for blood work, but the blood work is just being done on a very small subset.
Okay, so they can still engage if they don't do the blood work.
Yes, and in fact, just to let me say this again, we really need people both with and without psychiatric illness to do the work we're doing. So if your kid's over 10 and you can face filling out some more surveys, please consider doing this.
As a reminder, we have a current open research studies table out front, so I think you all might have materials for this, but also everything is on our social media, on the website also. Is there a time frame that a skill is lost and expected to never return?
If there is, I don't know it. I think I would wrap the question of catatonia around that. If there is evidence of catatonia, until you've treated the catatonia, you don't know what's underneath. If there isn't evidence of catatonia, I think it's a different question and one I'm not equipped to answer.
Thank you for answering these so quickly. We're getting through a lot of them. Another one asks, have all or most cases of catatonia been caused by antipsychotic meds, or can it just arise on its own?
It can just arise on its own.
Sorry, I'm just still looking through them because you're answering them at a good pace. Let me see. Any medications to be avoided for general anesthesia related to these issues?
I think it would be good to try to avoid the parts of the anesthesia cocktail that are antipsychotic or antipsychotic-like. And again, that's in the MAC letter and in our guidelines, and something to talk over with the anesthesiologist in advance of a surgical procedure.
And that's also on our website. Any advisories from the Medical Advisory Committee are under About Phelan-McDermid Syndrome, and then medical care and guidelines. They're the very first thing on there. Let's see here. Our child had a very bad reaction to lorazepam. She was aggressive and could not be calmed down. Have you seen much of that?
Lorazepam can make people punch drunk and loopy and disinhibited if it's not treating catatonia. And even sometimes when it is treating catatonia, it's a known problem with that class of meds. So it can happen. Luckily, not that often, but it's no fun when it does.
A question about autism. A lot of neuropsychiatric conditions seem to go with autism. Is it possible that a person with Phelan-McDermid syndrome has these symptoms but doesn't have autism?
Has which symptoms?
Neuropsychiatric illness or features of it.
I don't think I understand the question.
I think it probably has more to do with if everybody with Phelan-McDermid syndrome has a diagnosis of autism, which they don't. A majority of people do, but I don't think it necessarily has to go hand in hand with these symptoms. Let me see if I have anything else here.
While Kate is looking, let me say again my gratitude to the families who contributed their stories and the videos, and also ask you to let me know whether this was too hard to watch. Okay.
I'm hearing a lot of this was necessary from the crowd.
Right.
I have a couple more questions before we end. One of them says, why are antidepressants during periods of depression not such a great idea, or is it okay to try?
Great question. So one of the patterns that I think a lot of us have seen is that the first phase of this is either anxiety or what looks like depression, and then antidepressants are given and the person goes manic, goes very manic. So we're talking about a group who are at some degree of increased risk for bipolar disorder, for manic episodes. And in general, not just in Phelan-McDermid, one tries to avoid antidepressants in people who are predisposed to mania. It can be hard. It's a really common story in my experience of listening to families that the child started getting more anxious or more withdrawn or seeming more stressed by life, and somebody said, let's give them a little Zoloft or a little Prozac, and then things went boom.
Last question, are you compiling any data on the people evaluated through the ECHO consultations over time?
Oh, yes. And Alex is working on that.
And we also funded some research to do that as well. So if anybody saw Asif Rahman, who is working with Alex on that, publications will be coming out from all of that data too, and I think it'll continue. I think I can speak for everyone. This was a really helpful session. Please join me in thanking Dr. Kohlenberg.